Hello, my name is Dr. Pradeep Alexander. I'm an orthopedic surgeon in Toronto, Ontario, Canada. Today we're going to talk about the lateral ligament reconstruction of the ankle, i.e. the brostrom repair, using the trushot with the Y-knot shallow. So the lateral ligament reconstruction is indicated for patients who've had failed non-operative treatment. They have ongoing instability. There are multiple incisions that can be done for this. One is the inverted Mexican hat. The other is the more extensile curvilinear incision. Follows the lateral aspect of the fibula. I prefer using this one as it's more extensile. If there are damage to the peroneal tendons, this can be all repaired at the same time. So a skin incision is created, full thickness flaps, right down to the fibula. Care is made to try to actually identify the retinaculum as a discrete layer, which is repaired at the end of the procedure to further augment the lateral ligament reconstruction. So a sleeve of tissue is dissected off the fibula, exposing the talar neck at the same time. Make sure that we actually dissect out a discrete layer of the retinaculum, which can be done for the Gould modification of the brostrom repair. My preference is to use the trushot with the Y-knot shallow. The huge advantage is it's one step. Basically, I can hold the anchor at the appropriate level and drill and place my anchor under direct vision. It certainly simplifies the process. The bowl technique is drilling. The drill is then completely removed from the device. The anchor is then tapped down. We then push the button till you hear a click. At this point, you can then remove the suture out of the spool. The fixation is extremely strong and putting a lot of tension on this, and the implant does not fail under extreme load. The advantage of this anchor is it can be done with one person only, and 10 millimeter drill depth allows us to penetrate the bone without going through both cortices. Drilling all the way down and then pulling the drill bit out. Once the drill bit's out, impact and deploy the suture anchor. We then push the button till you hear a click. Once you hear the click, you know that the anchor has deployed. You can then remove the suture out of the spool and then remove. So I'm very happy using this anchor because of the strength involved. It gives me a lot of confidence that I can perform the best repair possible for my patients. Okay, we then pass the suture through the sheet of tissue. I usually use 2 for this procedure. I usually like to use a modified Mason-Allen type suture. I find it's strongest. It allows me to pull the suture through the tissue to confer anatomic reconstruction. At this stage, I usually have the assistant hold the foot in a dorsiflex everted position. This allows me to reattach the ATFL with as little tension to the repair as possible. With the ATFL reconstructed, then cut the sutures. This technique provides extremely strong repair.